what is healthcare? Healthcare is the diagnosis, treatment, and prevention of disease, injury, and impairments. Healthcare is delivered by practitioners of varying disciplines, varying sources of education, holistic and specialized. For indigenous societies, healthcare is practiced within the community by persons with experience. Healthcare for these societies is a right of all members of the community. Even in our own country, the first line of healthcare comes from within one's home, practiced by oneself. For instance, if I have a sore throat, I could tie a bag of onions around my neck, or put a sock, or put on some paper rug. Looking away. In most countries, advanced healthcare is performed by skilled technicians, funded by the community, and that's called a single-payer type system, similar to our Medicare system. In the United States, healthcare is performed by skilled technicians as well, but it is a privilege. So the poor, without resources, for them, healthcare is performed in the home mostly, based on information gained from friends and family, as well as TV ads, or not at all. U.S. healthcare is based on private funding until the Veterans Administration, Medicare Medicaid programs were created, because society recognized that some portions of our society had no health care without community support. But make no mistake, healthcare is big business. And it is a pricey business, accounting for 17% of the gross national product in 2013, and growing because the cost of healthcare increasing much faster than inflation. Clicking away. This slide shows typically the process for medical care outside the home. At the first junction, to the far left, if one is without health insurance, they are at that arrow to the right, where they have to assess whether it's worth the cost for the health care. Due to alliances between the insurance companies and mainstream medical providers, there's also a pathway, this is also a pathway for alternative medical treatments like acupuncture and chiropractic work. So taking the insurance route, coming the rest of the way around, this ends with the out-of-pocket costs, which I'll come back to a little bit later, describing what that means to the patient. Looking on to the next slide, this slide identifies places of common treatment. And home care could mean house calls, but that really is the case anymore, unless you call an ambulance. Most self-treatment is from consult with friends, family, the internet, and again, TV advertisements. Moving along to pharmaceuticals, there's a growing sector of the health care costs. Insurance companies put all drugs into formularies of tiers. Tier 1 drugs are not advertised on TV. Often drugs in Tier 1 do exactly the same thing as those in Tier 2 and 3. This slide with the pricing of it is instructive to remind us to ask our prescribing physicians and pharmacists for a generic product. There are also specialty drugs at the bottom of the page. And these are new drugs that are made oftentimes the day that they are administered. And some are in the tens of thousands per dose. The next slide shows the cost centers for why healthcare costs is climbing much faster than inflation. The first four bullets I will take up in the subsequent slides, but moving to the fifth bullet, the decrease in value of cost sharing by the patient, speaks to the fact that our plans before the Affordable Care Act, and still are in effect, had deductibles and co-pays that were set whenever you took the plan out. And if you took the plan out 10 years ago and you had a $500 deductible, $500 buys a lot less health care today than it did 10 years ago. So that's what that bullet refers to. The Patient Protection and Affordable Care Act in New York State are using taxes and fees on the health insurance industry to fund programs that are not specifically designed for the delivery of healthcare service. And malpractice awards continue to climb, but only for those that are privileged enough to be in the healthcare system. Those outside the system, they won't see these awards, which is a really strange twist because their health is compromised by the system. On to the next slide. Here are some of the advances in medical technology that are taking place. They're much more expensive than the predecessors. These are new tools, new protocols. For instance, 10 years ago, there were very few people that had hip and knee replacements. If you don't have one now, you're not part of the in crowd. Or 10 years ago, if you needed to lose weight, your doctor told you to change your diet and do exercise, but now they will add bariatric surgery to the list of options, and there's a big price difference in those costs. The next slide identifies the advances in pharmaceuticals that are now in the pipeline, and also the areas that they're working in. And these, well, I'll talk a bit about the U.S. patent system, which guarantees the pharmaceutical industry tremendous revenue. On to the next slide. There are federal state mandates that the insurance industry will use to raise as fodder for raising their rates. But these are not bad mandates in that they are providing great consumer protection. The next slide oh my God, everything you told me so far is very depressing. So why would I need insurance anyway? Especially if I'm, say, 40 or I'm 60 and I've never been sick a day in my life. Well, we never know when we'll become injured or develop cancer or a chronic disease. It could be that we've saved our money by not paying a premium, and then do not be able to pay for those treatments. But what happens in the latter days of our life? For the average person, 40% of our healthcare costs incur within the last year of our life. So health insurance is collectively pooling of resources, also known as health insurance premiums, for use by our community, collected together to cover the cost, a medical cost for the entire group. There are people called actuaries, which are statistical engineers, that look at this claims data and can predict pretty accurately the aggregate health claim cost for a population. The larger the population, the better their accuracy. The years that we are healthy, we support others. When the time comes that we need medical care, our community supports us. In that, any given year, 20% of the insured population incurs 80% of the claims cost. So we buy health insurance because no one knows when we or a family member may be one of those high cost 20%. The next slide is health insurance is really a contract language. It's all about contracts. They're called benefit plans. So the benefit plan is a contract between the health insurance company and the patient. And the language that is used in that same contract is used between the health insurance company and the provider. So that's how it's all tied together. On to the next slide. In its foundation, premiums are based on predicted claims from the benefit plans covering services. Of course, there are other assumptions in fees and expenses that cause the variation between insurance rates. If insurance companies are not allowed to exclude persons for adverse risk, which incidentally adds their bottom line, then the concept of risk pool that I just described works, and all members pay the same amount in any given year, no matter their age, previous, expected, or current claims history. The next slide shows another concept of health insurance structure, the cost from assuming risk. So self-insured plans where the employer, association, or employee welfare fund pays claims and creates reserves to cover those future unknown large losses. Self-insured plans will contract for administrative services with companies like Excel's Blue Cross Blue Shield that have a provider network. Experience-rated plans is a combination of assuming risk by the employer or the employee group, as well as the private sector. And this is where a number of members can support a risk pool, and they purchase an insurance product from the private sector, oftentimes tailor-made to their needs. And then they hold partial reserves at varying levels. And that's why there's a continuum for the experience-rated plans. And then finally, to the far right on the top and far left on the bottom is the community-rated plans, which are priced exclusively by the private sector, where they retain all the risk and are paid handsomely for doing that. Community-rated plans are the only options available for small employers, those under 50, and soon to be under 100 if the insurance industry gets their way in New York State, and also individuals. So they are stuck in the high-price community-rated plans. Next slide shows that health insurance is a three-legged stool, with a patient, provider, and insurance company, all tied together by the benefit plan contracts that we talked about before. So healthcare is truly between the patient and the provider. That's where it takes place. And then a system where healthcare is a privilege, and then the insurance company is an option. And anybody who's set on a two-legged stool will know it's not too stable. And that is the case with this health insurance plan we have in the United States. The next slide shows that patients with healthcare share the cost of healthcare through these listed mechanisms. The greater the cost sharing, the lower the premium. Hence, many entrepreneurs and small businesses select the high deductible models, which means that the patient assumes the primary risk in healthcare. The other major component of sharing risk is the out-of-pocket maximum. This is a critical item for consumers to understand and focus on when they're comparing health insurance plans. The out-of-pocket maximum is exactly that. It is the amount that the consumer is on the hook for in healthcare costs defined by your health insurance plan. Once the out-of-pocket maximum is reached, then the plan picks up all the rest of the cost. Some low-cost plans, though, do not have an out-of-pocket max. So these plans are not really called insurance. They are called cost sharing up to a limit. And then the consumer bears all the risk after that. The next slide talks about the Patient Affordable Care Act. And they created new plans, which I am calling level plans because they are called platinum, gold, silver, and bronze. These plans are different because all previous benefit plans held the patient share constant, and the inflation of price and technology was absorbed by the plan. These metal plans are designed to keep the ratio of the plan share to the member share equal. That's a huge change. This ratio is called actuarial value, and there are four actual variable levels for these plans. And so I've listed those levels, and what that means for the platinum plan is that the plan pays 90% of the cost for the average person, and the patient pays 10%. So when you get to the case of a bronze plan, then it's 60-40. So the metal plans are much different than the plans that were before because the copay, out-of-pocket maximum deductible will be adjusted every year to make sure that the actuarial value stays constant. The next slide is just a little filler that shows the cost versus value for the actuarial value, which is a statistical calculation that is run by the health insurance company every year through a federal calculator, and then it's updated. And so if you have a metal level plan, you will be receiving a notice, most likely every other year, of change in benefit with your patient costs being adjusted. The next slide shows that the government was involved very early in health insurance with Medicare and Medicaid. They are different. Medicare programs are funded through a payroll tax, but that tax is capped at $118,500 for reported income in 2015. With the wealth disparity that's occurring in the U.S., this structure is not adequately funding these programs. The same is true for Social Security. This funding shortfall adds more inequity and will add many more to the roles of those not able to afford health care in our health insurance privileged system. One aside about the Medicaid, which is 50% funded by the federal government and 50% funded at the state level, is that New York State has a very robust Medicaid plan, much more so than most any other state. And the safety net then is, which is supposed to be paid 50, in New York State is actually paid 50% of that is covered by the local property tax. And Paul Person wants to add something.
I just, while you're on this slide, a few years back, the feds actually changed the FICA tax, you know, the Federal Insurance Contribution Act tax, and Medicare is now taxed on all earnings, just Medicare. All the rest of it stops at the 118, just for your information.
Thank you.
That's all. Yeah, yeah, sure.
So on the side then is in New York State, 50% of the Medicaid cost is paid for by local governments, which means that was a tax shift from the income tax, which is the state revenue source, to property tax, which is the local government source, which means that the cost for Medicaid in New York State is paid for by those needing the program rather than those that can afford it, which is a huge change from any other state. No other state is doing anything close to that. The next slide shows that this is local data on the cost, average cost for a covered plan for claims by age group. And so you can see the under 65, which is closest to me, the average cost is roughly $400 per claim per covered life, and of claims are covered life per year. And the far left is for those that are on Medicare. And you can see that the cost is roughly the same. If you were to move column number 3 over to 2, then that would actually provide you with the cost of health insurance in the current system by age group. And what that would show is that without Medicare, that the age 65 and older would be off the chart. So we can appreciate that health insurance cost is prohibitively expensive if those over 65 were added to the current system and not supported through Medicare. When Medicare was established, pharmaceutical was a much lower fraction of healthcare costs. And now it is 30%, which we're seeing here, and climbing. So Medicare has not adjusted for the new pharmaceutical growth and cost. And so the orange on the Medicare group on the far left is showing that 75% of the cost of the medical costs for patients that are in the Medicare program. The next slide shows that healthcare, asks the question, should healthcare become a right or remain a privilege? Medicare, for the most part Medicaid, their health insurance as a right for the population. But for the rest of us, healthcare is a privilege. This privilege system has the U.S., which is rated by the World Health Organization for basic metrics of healthcare, ranked at 37th in the world, behind Morocco, Colombia, Costa Rica, and Chile. Of the 11 developed countries, U.S. ranks number 11. The U.S. healthcare system is available only to those who can afford it, is not working for our society, and is confirmed by the World Health Organization. Is Unitarian Universalists and persons with a value set that we take care of our brothers and sisters, making healthcare a right is a no-brainer. Nationally, it is called single payer, and in New York, called New York Health. Independent polls show that over 60% of Americans support single payer and making healthcare a right. It should be a no-brainer then for elected officials in Washington and Albany. But it hasn't happened. So moving on. The question is, why is change so hard? In 2013, healthcare was a $16.8 trillion, that's trillion, dollar business in the United States. 17% of gross national product. This is a big for-profit business. Even not-for-profits, like Blue Cross and Blue Shield, pay their CEOs and top managers 7-figure salaries. Not-for-profit doesn't mean working for the benefit of the civil society. The U.S. federal government is the best that money can buy. And hopefully I'm not the first person to tell you that. It works for the oligarchy of the 1%. Healthcare CEOs are making the kind of money to buy tickets to their games. Federal officials have removed antitrust regulations and funding of enforcement agencies, so insurance companies, manufacturers, and providers can swallow up small operators and vertically integrate. One outcome seen locally is for rural family practices to have decreased And also the general practitioners and specialists have been replaced by specialists who make more money and have additional hours. Big Pharma makes tremendous profits for the monopoly that they have garnered from the patent drug system. No other country allows this kind of profit and control of its manufacturer, which means limiting its supply and increasing price on a benefit that belongs to the society. When I speak to my elected official contacts, they all say that the hospital and health system lobby is the strongest in Washington, rivaling that of the military-industrial complex. Corporate media creates a narrative that the less financially fortunate in our society are there because of their choice, and that tough love will somehow change their taker attitude. Finally, the practice of gerrymandering creates a structural stagnation in the elected offices, where elected officials are no longer accountable to their are only accountable to their benefactors and not their constituents. In a republic, where the supreme power resides in the electorate to choose who their representatives are, then they would be truly accountable to the electorate. The oligarchy has taken control of the system of the representatives, and now the system is broken. The system is broken when it will not make health care a right, unless the oligarchy says so. Our next slide is describing the political landscape, and for those in power, but there are also those that are not in power, and they're working. So working to bring about change. The Patient Protection and Affordable Care Act, also known as Obamacare, is a legislative initiative that has become law. Although health insurance costs are continually challenged in front of although this law is continually challenged in front of the oligarchy that has controlled the Supreme Court, it is still remaining. So how the Affordable Care Act became law is worth a few moments of discussion. The Affordable Care Act actually brought about some significant reforms, like fully covering preventative health care for those in network. There was no rejection for prior conditions when you apply for health insurance. And there's a reimbursement system that holds providers accountable for quality service. But those gains came at a price. The price is that health care remains a privilege, and that through a taxation strategy, the law drives previously uncovered persons to the health insurance market. So this adds to their business and potentially to their profits. The Heritage Foundation, a conservative think tank, developed health insurance, what I call the Health Insurance and Industry Insurance Act, or the Affordable Care. In spite of Republican railing against it, I believe it passed and has been upheld to date by the oligarchy Supreme Court because the oligarchy stands to gain from this law. Other initiatives happening around the nation are single payer in the New York health system. And we have our own Rebecca LG, who I've asked to, has just been to Chicago to learn about strategies for single payer and is intimately involved in New York health. So I've asked Rebecca to spend a couple minutes in just describing those two initiatives. And I'll come back. Rebecca.
Thanks, Don. Thanks to everyone for being here. Yes, we had our Single Payer Strategy Conference in Chicago last weekend, where the PNHP doctors came together for their conference, and the single payer states came together. They have a group that are doing local initiatives in the states who meet regularly, and Labor for Single Payer came, as well as our kind of mother organization, Healthcare Now, which has been working for a national healthcare plan, HR 676, John Conyers' plan. And I think most of you here have a pretty good idea of what single payer is, but basically it's a publicly funded, privately delivered care system that would provide comprehensive care for everyone in the system. And it's totally accessible by everyone. Our mantra is everybody in, nobody out. And it provides the same plan for everyone, but some people begin to worry then when they hear that everyone's going to have the same plan. However, that same plan is much more extensive than most of us have who have private insurance. And it covers dental care, vision care, hearing, mental health parity, and all necessary medical coverage. So instead of losing ground and having a less comprehensive plan, we would all benefit from a more comprehensive plan. So we've been focusing, as I said, on national up until the ACA or Obamacare was passed. And at that point, it became clear that the national plan was what it was. It wasn't what we wanted. It wasn't what we need. And so a lot of states began to focus more at the state level, feeling that if we could get a few state plans passed, then that would influence the political landscape enough to drive a national plan, which is obviously our ultimate goal. So in New York State, we have what's called New York Health Plan. It's been sponsored by Dick Gottfried for 22 years, and he has worked tirelessly on this and brought it to a vote 20 odd years ago, and it passed the assembly at that point, and since then it's just been kind of in the background with no movement. So a year ago, we formed a New York Health campaign to really push the New York Health Act at the state level. And a committee was formed, labor was involved, the nurses were involved very heavily, and doctors, PNHP in Metro New York, and we've been having monthly strategy calls to plan a strategy, which last spring we, or it actually started in the winter, we held 6 legislative hearings. The closest to us was in Syracuse, and a number of people from here testified at that hearing. Others were held in Rochester, Buffalo, Albany, and New York City. And from those hearings, we've gathered incredible testimony from people of all walks of life and all income levels who are suffering under this system. We then had a big petition drive because part of the problem has been in the past years is not being able to bring the bill to a vote. And when Sheldon Silver stepped down, this opened an opportunity for us with Speaker Hastie to really put pressure on him to bring the bill to a vote, because we felt pretty confident it would pass if we could just get it to the floor. So we worked pretty hard on a petition drive to get lots of support for bringing the bill to a vote, and presented these to Speaker Hastie. Various people met with him, and we talked with our different legislators, and they signed a letter. Barbara Lifton has been one of the co-sponsors of this bill for years, and she signed a letter to Speaker Hastie urging him to bring it to a vote, which then did happen at the end of May, and the vote ended up 92 in favor of the bill and 52 against. So we had a clear majority, almost 2-1, and that was cause for celebration that we hadn't reached that goal for quite a while. And so now what we're looking at is phase 2 of the campaign, and that is a heavier lift, and that is to move the Senate. So at this point, we are, oh, and I wanted to add, after we passed the vote in the Assembly, locally we started doing local resolutions, and part of that was at the encouragement of Dawn to go to the Tompkins County Council of Governments and ask them to pass a resolution in support of single payer. So we gave the members of that body, which represents 17 municipalities in the area, gave them lots of background material, and we went to, a couple of us went to a meeting. Anita, I want to welcome Anita Watkins, who's come here today, and she's part of our Finger Lakes for New York Health group. And I would invite any of you who are interested in this topic, and Judy also is a member of the group. And they've been really supportive in trying to move this issue locally and beyond Ithaca. And so we've been having resolutions brought to municipalities, and as I said, we brought it to the Council of Governments first, feeling that if we could convince that group, they could then go back to their 17 municipalities and try to get resolutions passed there. So that's the process we're working on locally, and we have passed it at the Tompkins County Legislature, Common Council, the Town of Ulysses, Town of Caroline, and the Village of Lansing so far. We have resolutions in the works in Dryden and in the town of Ithaca. And we hope not only to pass these resolutions, but then to speak to local members, residents of these communities to try to get them more educated and more in line with us. Excuse me. So that they can then speak to our senators, because as I say, that's our next heavy lift, is to move the Senate. And so we need a lot of people writing to our senators, going to meetings. There's going to be a town meeting on November 19th locally with Senator O'Mara, and we hope to have a contingent there who will speak about single payer and asking him why he hasn't signed on and what he needs to know in order to convince him. We also are targeting them statewide. I was on a conference call Friday where they're targeting about 5 Senate districts down in the metropolitan New York, and 2 districts in Buffalo, 1 in Rochester, and Valesky's seat in Syracuse. So they're hoping to change some of the seats there. I also hear there may be a race in our district for Senate. So if that happens, I think that's going to be a golden opportunity for us to get involved, to support a candidate who would be more in line with our thinking on this topic than our current representative. And so we're going to be working on that. They're going to be holding labor breakfasts in the different municipalities in Syracuse and Rochester and Detroit and Buffalo to try to get more support in these communities. So these are areas that we're going to be working on. And just in closing, we have some resources. If you have places where you think people would be open to having a meeting, we have Barb Harrison's documentary stories from local people who many of you have seen. We have a PowerPoint presentation that we presented in Oneonta on Thursday, and Anita and Carolyn Kenyon, another member of our group, have put together another talk that discusses New York health and compares it to the Canadian system, which Anita is very familiar with, having lived there. And we have a new documentary called FUSIT that previewed at our conference, and it's geared to small businesses, so I wanted to talk to Donna more about that. and see how we can get it out to small businesses. It's a very professional film, and I think is very not only informative, but I think it's pretty convincing that business would really benefit from this bill, or from a national bill or a state bill. So this is where we are in our campaign, and I thank Don for giving me this opportunity.
You're welcome. All right, so moving on to the next slide. Thank you, Oliver. So we've been framing how the healthcare system works and health insurance and so on. And we just learned about the state and national initiatives. And then there are also our alternatives. So although we all need to be leaning into the weight of the load to get single payer New York Health Pass in our community for our brothers and sisters, one can get really cynical as time passes and the oligarchy uses their control of the structure to hold on to the status quo. But there are things that can be done in smaller groups and the state and nation, and these are just some of those. Locally, we've created the Municipal Health Insurance Consortium. It's got a long acronym there, but I'll just call it the consortium. And with that, we were able to, this is something that's actually allowed by New York State law. And although, like I said, the word Article 47 wouldn't mean much to anybody in this room, but I will say that it allows local municipalities of any size to come together and form a risk pool. And so this law was adopted in 1993, which said it was available for anybody to do since 1993, and the only one that's ever done it is the Tompkins County Health Consortium. And there's a reason for that, because there's a lot of regulation that goes with it, and there's a lot of hoops to jump through. But nonetheless, we were able to do that. We broke through the barrier, and in the first year that we started the consortium, we saved the taxpayers in Tompkins County $928,000. We saved them only by allowing the smaller employers, like the town of Caroline, at 150, to join into a larger risk pool. So our health insurance premiums went down 30%. And that, we told that out and get $928,000 pretty quickly, which we did. Since that time, in 2014, we documented that we saved the taxpayers in Tompkins County $1.7 million additional in that year. For this year, 2015, we'll save over $2 million to the taxpayers in Tompkins County. And the reason for that is that it's a very efficient plan that has absolutely very little overhead. There are no 7-figure salaries, there's actually only 3-figure salaries for people because they're just getting lunch and serve on the board of directors. And so with that, the premium increase for 2015 was 5%. For 2016, it'll be 3%. In 2017, 4, and 18, 5. And this, when you're thinking about what you might see from the private sector, they're talking 10% plus. And we've had many municipalities asking them to join the consortium because they just got a letter from Excel saying 15% increase for 2016, and they can see the cost difference. And so, wouldn't it be great if we could do something like that with just the regular citizens? And we have, some larger benefactors in the area, like Park Foundation, that might be helpful to see this. And it turns out that at one time we could have. But due to a lack of oversight by New York State and overzealous plan directors, some of those plans actually became financially unstable and left their members holding the bag with paying health care costs. And so the oligarchy, which are writing community-rated insurance, found this as a great opportunity. They jumped in and revoked the law, and it has not been replaced. Creating that law, working on the same structure as the Article 47, is an opportunity for us that we shouldn't overlook, so we can get control of our healthcare costs. But let me be very clear that this still makes health insurance a right, a privilege, and not a right. So there also are free health clinics that provide health care for the unprivileged. And they need financial support, and I encourage your consideration for your list of charitable contributions of time and money. And we've already discussed political action opportunities, but our final group is understanding, supporting, and spreading the word about hospice care. The reason why hospice care is so important is, I mentioned earlier, 40% of the average person's healthcare costs occurred in the last year of their life. It occurs because of heroic efforts to extend a life, and it happens at great expense. Most physicians don't advise on palliative care. The dialogue and end-of-life decisions can raise awareness that will decrease healthcare costs, and in most cases improve the quality of life for those who know those remaining days. I want to thank this program, the Adult RE, for the series last year with Liz Einstein on year-end end-of-life decisions. Very informative. Individually, there are choices that we make every day that can reduce our healthcare costs. We are walking chemistry sets. Our bodies are chemical processing units. Making it a priority to understand how our body processes the energy we ingest from food is an important step to wellness and reducing expense. With all the man-made chemicals in our environment and genealogical markers, this is no fountain of youth. But I highly recommend these two sources, a book called The China Study by Colin Campbell and a DVD or a movie called Folks Over Knives. They're very interesting and eye-opening to learn about diet and how you deal with your food. I'll also point out that Colin Campbell actually is a Tompkins County resident, has a foundation here in Ithaca, and he may be a good speaker for this RE program in the future. You can also join and financially support health groups. This is just a small fraction of the local groups. There are many opportunities out there. And finally, many in our community, employers are starting to make the wellness connection. I think Cornell has been 22 years. Yeah, so they've actually been leading the way for a long time on that. So making wellness an integral part of our culture is another action step that we all can take. So one more, let's move on to the next slide. This is just a wellness vision that I picked up at one point in time, making a statement about wellness. But if you look at the logo, wellness is more than just your body, it's also your mind and spirit, and that's part of the whole wellness strategy that would fit in very well with the dialogue that we have at this church in this RE program. Moving on to the last slide. These are the key aspects of a wellness program or strategy. It's important that you know your numbers and get them checked annually. Most chronic diseases are curable if they're detected early. So early detection is a choice that we all make. Lifestyle changes like reducing stress and exercise are all part of things that we can do to keep ourselves healthy, which means we're happier when we're not sitting home with a handkerchief to our nose. So just in closing, I will say that I just shared a lot of material with you about healthcare, and some of it may be completely confusing, and I'm sorry about that. I'll try to do better if you ask me questions, or if you have some comments. So Jim, and then we'll go with Rick.
Question to Rebecca on the New York State Health Program that you incorporated. Why incorporate Medicare as opposed to, I can understand Medicaid in the program, but why Medicare in this federally funded already? Wouldn't that add another layer of bureaucracy?
No, the plan would be to incorporate everything that we get from the federal government now in terms of financing into the state plans, so that it would be, we would have a health fund that's dedicated just to health care provision in New York State. So Medicare is good, but as many of us are seeing, our premiums are going up. There are gaps. It doesn't cover everything. Most people need a Medigap or a Medicare Advantage plan in addition, which adds the private insurers into it. So Medicare as it stands wouldn't be as efficient and comprehensive as being able to wrap it all into the one plan. So that would be our ultimate goal. If that's not possible because it would need a waiver, then there are plans to keep Medicare and try to do for the rest of the population, but that would not be as efficient.
So what the funding of this would have to be based on the state income tax?
It would be payroll tax.
Well, payroll tax.
Right, payroll and, yeah, it's based on what people make,
But
so
that
it's
doesn't
a graduated.
It doesn't cover the higher income levels because most of them are not payroll tax.
Well, no, and there is a provision to tax dividends and capital gains for the high income levels. So that's part of the financing process of it. Anyone else want to chip in?
Just wanted to add one more comment about the Medicare Advantage. To be perfectly clear, that is a very low-cost supplement to Medicare. But it is low cost because the federal government is supporting that with subsidies to the private health insurance company. It's called welfare for corporations. But be that as it may, we currently have the austerity hawks in Washington, which are looking to cut that funding. And so you can expect that those that are on Medicare, and you were thinking about Medicare Advantage, your costs are going to go up. And those premiums on Medicare Advantage are now creeping up each year. And so that's just another thing going on around to kind of raise your antenna about what's happening in Washington around Medicare and its federal support. So Dick had a comment, and then I think Bob has one.
Question, what's the, what does the medical community, doctors and other providers and so on, think about single payer?
So I think probably Rebecca has more. Yeah.
Well, we have a number of physicians groups that do support single payer, but they tend to be more general practitioners and pediatric doctors. A growing support, however, is med students. And so I'm feeling that as in the future we're going to have more and more young doctors coming into the system who are supportive. Those who are not supportive tend to be the specialist doctors who are gaining from the system and are at a much higher income level. However, one of the ideas of a single payer system would incorporate giving incentives for doctors to be general practitioners and raising the income, because there is quite a disparity between specialist doctors and general practitioners. So that's one issue in terms of doctors. I don't know if anyone else agrees.
Right now, for one of the first times in quite a few years, the American Medical Association is getting involved because our healthcare system, everybody has a bad healthcare system one way or another. And so they're getting involved because of the oligarchy. And we're starting to see some antitrust suits. So that's the American Medical Association is finally getting involved a little bit, which is great,
But we do have a large Physicians for National Health Program group, and they do a lot of the research that we use in terms of economic research, and also research on numbers of people who die every year and things like that. So that group's been very involved over the years.
So I could just comment from someone who lived in Canada for 28 years and was covered by healthcare, excellent healthcare there, that there should be incentives for doctors to do this because A, it relieves them of enormous administrative costs that they have now in dealing with, hundreds. In fact, in one place I saw over 1,000 different insurance companies with different tiers and different, plans, so they have to employ these massive number of people. When I was in Toronto, I went to a practice that had 4 doctors, and they had someone who worked part-time who did the appointments and the billing. And there's a hospital in Toronto that has 417 beds, and it has 5 people in its billing office. Cuba Medical Center has less than half that number of beds, and they apparently employ 25 people to do the billing. So there are enormous savings to the provider. Plus, your provider, your doctor, is not going to spend any time on the phone arguing with an insurance company that you really should cover this procedure for my patient. In Canada, if the doctor recommends your treatment, you get it. There's nobody in the insurance system who's going to deny your treatment to you.
So that suggests to me that a conversion for the United States or New York State to single payer all the way would take away a lot of jobs for people that are doing all of that administrative stuff.
That's quite right, yeah.
Well,
I mean, that's the only, frankly, that's the only way you're going to save money in the system. Now, the New York Health Act has provision for taking some of the savings that would come and using that for retraining people, job retraining. And I mean, I would like to see, instead of people pushing files around, we need a lot more home healthcare workers. We need a lot more people doing other things in healthcare than sending out bills for $6.32.
and this movie, FUSIT, has a segment about the Canadian system, and they visit doctors in Vancouver and have a very interesting discussion about the differences in the system.
Actually, we should show that,
Yeah, well, here, we'll
So,
have a showing here.
Yeah, we could back this meeting up with it.
So Bob, I have a question.
Helen, go ahead.
Okay.
This might be irrelevant to this discussion, but it's something that I live with every day. I have burning mouth syndrome. Our system of medicine in this country does not know what that is, but I'm living with it. And so I don't know if any of all of this is going to make any sense to me in terms of my condition. So that's another issue that I'd like to have us just think about, and what does that mean to a lot of people in this country who suffer from this.
So with the current private sector health insurance model, they probably will not recognize it until they find a way that they can make money off it or understand it. But is it, I don't know, is there a way, will this be covered under the single payer program? Do you know how that would?
Well, all medically needed services would be covered, so it certainly sounds like that's a medically needed service that a doctor would identify
It hasn't been identified yet to,
by any doctors.
they don't know what to do, especially the Cayuga Medical.
Well, one of the advantages of a single payer system is that you can go to any facility and you'll be covered. So you're not as limited as we currently are to local facilities or in-network doctors.
Okay. And Jim?
I haven't heard the answer to your question is why is it so hard? It seems to me that even with the Affordable Care Act, there is a huge voter opposition to it based on, I think, in large part ignorance. But the second part of it is that we haven't convinced the overall public that health care is not just a privilege or a right. There's a psychology here that's not working in the context of maybe it's based on the notion that inherent individualism is one way of raising yourself up from the bootstraps or whatever it amounts to. But so I don't know. What's your thoughts on that?
So Rebecca may have the national numbers on how many people are in favor of a single-payer system. Last I had seen, it was over 60% and some
70%.
70% now. So the comment that you made that people don't get it, they do. The reason why we don't know that people get it is because corporate news controls what information is shared. So we could have rallies in Ithaca and all around New York State. They had hundreds of people showing up at it, and we would never know that this is happening, ever know, because the news media doesn't allow us to know that. So when 70% of the people think that this is something that's important and we should be doing, and you make the comment that they don't know about it, it's because of the current.
Well, I mean, it goes back to the same question, because when it comes to electing representatives to state or Congress, the same people are supposedly the 70% of the people that support this idea don't vote that way when it comes to electing the representatives.
Yeah, and that's part of election politics. So if you were to think back to Martha Robertson's campaign, when you left Tompkins County, they didn't talk about single payer. They didn't talk about any of the issues that affect people. What they talked about is the fact that she was liberal from Tompkins County. That was the whole issue, and that was enough for Reed to win. And the issue became all about who Martha Robertson was, and nothing to do with the issues that were important to us. And you can thank the Koch brothers for pumping tons of money into this district to raise food issues that had nothing to do with us. And so the oligarchy has control of the process. And so things like the Bernie Sanders campaign and others for the grassroots to come together and start finding their strength. At this point in time, every time they find a way, every time the group has a strength, like they have unions. So the oligarchy's been breaking unions up. They just keep finding, every time they find a strength, they keep trying to break it up. We have to be stronger than that and smarter than that. So Bob, do you want to get in on this before he does?
Okay, I'm not sure if my question is helpful at this point, but first I've got a question, and second I've got some sort of a puzzlement that I don't know how to formulate into a question. First one is, your cooperative, municipal cooperative for healthcare, how would that be affected by single-payer programs? How would those that are, in fact, grassroots organized, the free health clinic, how would those kinds of initiatives be affected by single-payer?
That's really quick.
What? That's quick.
Answer really quickly. It goes away.
They
The health consortium will no longer exist.
Then the follow-up question on that, is that a good thing if we lose important wellness programs that might be built into the healthcare system?
So from my perspective, it is a good thing.
Okay, so
So
the
because
single
you're making
payer
now-
could
making
in
healthcare,
fact
right.
incorporate wellness programs, okay.
So what we provide with the health insurance consortium is a privilege to those that work for municipalities.
My
And
second
the-
follow-up question then is more important.
Just the health clinic, we work with them a lot, and they say, we wish you would put us out of business. They're getting more and more people since the ACA are coming to the free clinics, so they would welcome that.
Okay, there are other aspects of getting wellness programs put out of business, and here's my puzzlement, and I don't know how to formulate it into a question, and that is about the 150, 200 years of monetization of our social relationships under capitalism. The notion that we save money by not occupying a hospital bed, let's say hospice for example, saves money. But it primarily saves money by transferring care from paid to unpaid services. Primarily a community and a wellness program is taking care of each other. A community like this, for example, can take care of each other and therefore bring it out of the monetary system. Is that a good thing? Is that a bad thing? How do we coordinate the part of the healthcare that's monetized and that part of it that is voluntary? Possibly, if it's voluntary, it's possible that we are triggering the spiritual and social mechanisms that are important for maintaining health. In other words, it's not merely reducing costs, it may be, in fact, I have a hard time conceptualizing the relationship between a healthy level of monetization of the community.
So there are wellness programs that have been documented with larger corporations that can actually enforce a wellness program. And they actually provide incentives to get people to participate in a fairly significant financial incentive, so they get a fairly high rate, 75%. And they're seeing that healthcare claims prediction is actually decreased. So no longer increasing, even if it's 3%, they're actually decreasing. For Excelis, they have a Blue for You program that they offer to their employees, and they saw after 3 years a 7% decrease in claims as a result of their wellness program. So 7% is essentially what increases each year, and that, as they add more people, that continues to grow. So that having a wellness community strategy is fine, and it actually is it helps us save costs of healthcare, and it also keeps us healthier. All things that are good for us, but we're still working under the umbrella of a private sector provider network, and that's where the rub comes in when we were talking about the capitalism. How do we break through that? And the only way you break through that is to just do away with that private sector and make it essentially all funded by a public program called single payer.
Let me try to formulate it a little bit. Let's imagine we have people out of the hospital in the home, either for hospice or for home care, and we find that the people in the household are there to put a strain on their ability to work, and therefore many people don't work. And don't we create pressure then to say, wait a minute, these are getting free services, shouldn't they be paid? So those people are now doing voluntary work, aren't we in fact building up a claim for adding them to the payroll and therefore increasing the cost of health care?
So so you could be paid for doing what you're doing here at the RE program as well.
I haven't started a union yet. That's of course in the voluntary system, that is the dilemma. We could be charged, the FUSIT here could be charged for the voluntary services because we're providing service and therefore we could be taxed for it.
So the reason why people are typically staying home is because they've done a financial analysis, which says that they're going to be ahead by staying home rather than hiring somebody to come in and provide 24/7 for their...
That is exactly the question. Are they doing a financial analysis or are we doing a spiritual analysis? Saying, despite the fact that it's costing me money, I want to stay home.
Yeah. And in some cases it could be the spiritual. I don't know. I would just have to say that knowing what the cost is for 24/7 home health care, because I've been considering that for my mother, that it's just, so it's not, that spiritual would not be part of it. It would be a benefit. It would not be a part of the decision.
Vermont has tried to, is the process of trying to impose a single payer?
They,
Hasn't-
yes, they had a plan, they had a governor who ran on this plan, and it was not a totally single-payer plan because they couldn't roll in Medicare and some of the other issues because they have regional Medicare that is in other states. It's a complicated system. So they had to step back. They are still continuing to work on it. The Worker Center there and all the organizers there, they were in Chicago and were talking about it. But it came down to a political issue, and I think we all know that the closer you get to actually making this change, huge amounts of money came in during their last election from outside the state, from Republicans and Koch brother kinds of funding. And the governor was just narrowly reelected. I think he got very concerned and backed off and put forth a budget that wasn't viable for doing the plan. So it came down to political pressure from the outside primarily. that was against it. But they haven't given up the idea, but it's still not here for sure.
Strategically speaking, it seems to me that this raises all kinds of complicated strategies. I mean, I think in general speaking, most people, as you pointed out, agree that single payer or some single source of administering healthcare is a good thing. The problem comes into the structure of our both political and economic system that is going to have to be altered in such a dramatic way that politically speaking becomes extremely difficult to do this transition. That's the problem. And of course it starts with Citizens United. I mean,
Right.
you know, if that can't be overturned at some point, then I don't see how we can make this transition.
Well,
That's
Medicare,
probably-
Medicare works.
So that's probably the way we should,
Medicare's got
the way we should end today's conversation, because it's quarter after. But so everybody right now, from Jim's comment, knows that we have to get our pitchforks and stand out on the corner and start increasing hell, because that's the only way the system is going to change. The oligarchy is pretty comfortable with it. They've got the system completely bought, and we have to stand up.
Want to take this opportunity to say thank you to Don and Rebecca, and appreciate your good. Hopefully we're going to be more